This is On Diversity, a podcast series by the Institute of Policy Studies, Singapore. This is the third season, and I'm your host, Liang Kaixin, Associate Director of IPS and also a former journalist. Today's episode is on palliative care for the young and old, and we have Dr. Chong Poh Heng, founder of Star Pulse, a palliative care service under HCA Hospice Care. We also have Ying, founder of Happy Ever After, an end-of-life support, care and planning partner. Welcome to the podcast today.
Thank you for having me.
Well, first thing first, I'll just have a short introduction about Health Minister Ong Ye Kung, because he just announced that he will be trying to boost palliative care at home and give more support to caregivers. So to Dr. Chong and Ying, what are your thoughts on the current state of palliative care in Singapore and what more can be done?
Perhaps I will jump in first. Yep. So I was very encouraged by Minister's vision of how he sees the palliative care scene evolve, over the next 5 years ahead of us. So I think specifically he was noticing that while so many Singaporeans really, wish to spend final days and weeks and months in the home setting, sadly the reality is that up to 60% of our folks in Singapore actually eventually end up dying in hospital. So I think he hopes to bring this number down by 10%. It is a very ambitious vision, but he has outlined quite a number of strategies and has engaged the community here to think about how they can be, put in action. So in a nutshell, palliative care really is about helping someone to deal with a serious medical illness. Because if you imagine that somebody is now diagnosed with an illness, and this somebody need not be someone very old. I was just having a conversation with someone earlier about how palliative care might be required by anybody of any age. So to be diagnosed with a serious illness, you could be a child, a teenager, a young adult, or a middle-aged person. It's not something that is the privilege, for want of a better word, of an older person. So therefore, palliative care hopes to reach out to these people, because once you're diagnosed with a serious illness like that, your whole life changes, your perspective about the future, your hopes and wishes, and your current, I suppose, I wouldn't call them struggles, your own lifestyle, your living, your profession, your family, really turns upside down. And that's where suffering happens, and that's where palliative care hopes to minimize in terms of suffering, and hopes to actually bring back that fervor to live, that passion to sort of enjoy every moment while it lasts.
Okay, how about Ying? How about just tell us what you do, and also how do you see palliative care for your profession?
Okay, so I'm establishing my practice to be an end-of-life doula. Basically someone who journeys with somebody else through their end-of-life journey. And I think I'm also trying to define it very widely, because actually every moment that we're living, we're dying. So I guess in a sense, anyone who is prepared to talk about dying at whatever health condition, I'll be happy to journey with the person. So in this last couple of years, I think this is when I actually started to go more deeply into this work. So I have actually been volunteering mostly at various hospices, just to understand, I guess, what it is really like to be at the end of life. Because I think that is the sure part. No, actually, it is the only certainty in life is that we will all die one day. So I think for me, the way that I see it, based on my, I would say, pretty limited experience, is that palliative care is something that I think should be extended to anyone at the start of their diagnosis of a terminal illness or a life-limiting illness. From what I see, at least based on what I read from Singapore Hospice Council's website and the way that Singapore defines it, at least, is that palliative care is more or less synonymous with hospice care, which hospice care, again, correct me if I'm wrong, really kicks in at the really final stages of life, a year before, 3 months before, weeks before. But palliative care, I believe, should be introduced even earlier, because I think dying is a very difficult to process idea, experience. And it really takes time. And anyone who is actually diagnosed with any form of life-limiting illness would inevitably think of death and dying. But of course, being very life positive, we talk about treatments, we talk about next steps, we talk about fighting the disease, we talk about conquering and winning. But the possibility of death is always just lingering. It is very important to engage the person with this issue already, so that we can start thinking, not that I'm going to die immediately when I get an indication that I may have cancer in 10 years, right? But at least to get that conversation started. Yeah, so I think that it is very important to introduce or expose more people to the option of palliative care, to talk about palliative care. And I would hope that it can be brought even further upstream than whatever that we're offering today.
Yeah. So Dr. Chong, because Ying mentioned about palliative care equates to hospice care, right? So I mean, you work in a hospice.
Yes.
So what are your thoughts about this?
Well, yes. I suppose different people have different labels for almost the same thing. However, I think I agree with Yi that palliative care really is very much more upstream. Sometimes we like to think of palliative care being offered at diagnosis, and very much the work that professionals like ourselves do is around helping somebody to come to terms with a diagnosis that is devastating, with real consequences, and at the same time helping them to navigate the health system, to make some of those very difficult decisions, to chemo or not chemo, to do surgery or not. And if at diagnosis you're offered, not very much because the disease is quite extensive, or somebody is too old to receive any treatment. I hope nobody is too poor to receive any treatment in Singapore. Then is to help them confront and embrace a different life of, perhaps maybe more defined expiry dates, where they can spend every day enjoying themselves, finding meaning, returning back to their first love and discovering what else is there that they haven't done. And that's where the bucket list comes up. So I think it runs the whole spectrum of different interventions, from difficult decision making to helping somebody to live as well as possible, whatever comes. And moving on then to hospice care, about how if the disease becomes more severe with a progression, how you can still continue to enjoy decent quality of life and not suffer the ills of a sickness, whether it's in management of pain, helping them to continue to stay functional and independent, so that, if you imagine yourself one day having to have somebody change your diapers, how good can that be? And how does that translate to, that emotional or psychological sort of preparation and acceptance of that reality? So it's all of the above. And then moving closer and closer to death, how do you want that to look like? Where should it happen? Who are the people you want around you during that time or moments? Yeah, I just stop here. So I'm not even talking about planning your funeral and everything else, but that there are so much you need to do, and therefore, get on with it. Know that it's there. Don't run away. Like how Jia Ying mentioned about how people get very busy, fighting an illness, conquering. I don't know. So I think a lot of people spend needless time and energy and resources trying to battle something that is not going to go away. Yeah, I'm not saying that you give up before you even begin trying, but do what we often call parallel planning. You hope for the best, but prepare for the worst.
Okay. Dr. Chong, I think just now when you mentioned about wanting to increase the number of people who can die at home, what do you mean by that? I think Minister Ong also mentioned about it. And doing that, are there any limitations to help people to die at home instead of the hospital or hospice?
It's a $1 million question that the ministry as well as all the healthcare professionals in Singapore are pondering at the moment. Like everything in this world, it is a very sort of complex, multi-layered consideration. So it's not easily reduced to like one or two policies or one or two interventions or, even a service to be set up to do this work of bringing people from hospital back home. So firstly, I think this vision actually stemmed from previous surveys that had been done both long time ago and in the recent past of how consistently more than 3/4 of the population, when they are polled, whether young or old, they will want to, die at home when the time comes. However, the reality is more than half of them will end up dying in the hospital. So that's the statistics. And Minister Ong actually cited his own personal experience when his parent actually passed. How when he was able to nurse the parent at home, it was a very warm and familiar space that was created, and it allowed him to be the caregiver. And I like to think that, that is the way that most of us would want to spend our last moments. And he is hoping to then expand this benefit to everybody, at least 3/4 of us who had declared that we wanted to spend last days at home, to be able to enjoy those moments as he sort of thought back in memory, all the savor those moments that he spent with his loved one. So I think that's a really good vision. But however, in the real world, there are some patients who had wished to die in the home. However, at the last minute, they will change their mind, either because the condition becomes severe or problematic, or they actually don't want to burden their caregivers when they see how, they juggle work and caregiving, how they needed to spend money to either get help, either with domestic helpers or, professional carers, and also how, they were all losing sleep and quite emotionally drained in the act of caregiving. So many times, some of our patients actually surrendered themselves back to the hospital because they really want to release, their family caregivers from this burden of caregiving. And yet there are other situations where we have got loners who absolutely don't have family. These people, even if they want to stay at home, I as a professional, I could never sort of feel like that's the appropriate thing to do. And sometimes the home can be quite a miserable setting, which some of us really feel kind of morally wrong to host these people at home because they lack the environment, the safety, and many other aspects that is decent enough for someone to spend final hours and eventually die there. So there are many factors to consider, but again, like every difficult thing we do, we make the first step, we chip at it little at a time. As long as we can save someone, just one, that's good enough.
How Jia Ying comes in at this point? How do you help these patients who want to die at home?
I would imagine my role to be someone of an advocate. Yeah, to advocate for this person who may not be able to navigate the system, may not understand their options. I think that there will be some people who don't understand even what it means to die at home. Like, what are the things that are required? And there's actually a lot of logistics as well as administration and, just coordinating people to be around another person, to care for the other person until the person passes away. It's actually a lot of administration, logistics, understanding forms and things like that, which in hospice settings, we have social workers as well. But I think, at least from what I'm seeing, is that the social workers are also very stretched. So the way that I see myself coming in is really extra capacity to spend more time with the patients who are dying and to better advocate for them and to advocate for their needs, their wants at the end of their lives.
Really? Yes. I think giving people options is the first step. So we mustn't go away and tell people that this is the only way. So when things get tough, you just call 995 and you send your loved one to hospital. And that's the most legit place to be for someone who is very ill. We have seen so many different sort of experiences of various families at different strata in society, whether rich or poor, well-resourced or otherwise. They have been able to actually look after the loved ones so well, in spite of lack of resources and support. But what is important is that actually we have a big society with community, with people with such big hearts, right? And of course, professional services like ourselves, hospice services at hospital levels or inpatient settings that can provide for these patients and families in the community. So I dare say that if you are clear about your choice, if you are determined to do what you can to the best of your capacity or capability, you will not be short of healthcare professionals who will be there to assist you. So the job is still yours. We're not taking that away. But what we are there to do is almost like a tour guide that helps you navigate some of these vagaries of, end-of-life care. I suppose it's really, we are victims of our success, really, because over time, can you imagine, like decades ago, dying at home is like quite a normal thing. However, with advance in science and medicine, what we're seeing is a lot of outsourcing of these, what we call end-of-life care to the professionals in the institutional setting, until it becomes such a strange and odd affair that people cannot imagine this happening. I think this is a gradual, what I will call, professionally, medicalization of death and dying that needs to change with time. And I suppose like everything else that goes back retro, this is one of those things I don't mind embracing, something old-fashioned, which is to bring back that warmth, that family-oriented atmosphere, and that returning back home kind of feeling when one begins to wrap up your beautiful life in the past.
I have a question, because just now when you mentioned that when patients are at their last hour, last minute, as family, if you see the person is suffering or like in great pain and all that, and you panic and you call the ambulance. I can't imagine not calling the ambulance though, for myself, because you don't want to see the person suffer, right? So how would you educate people, and what kind of conversations are we trying to have to educate everyone to embrace this then?
If I might take that question, and I would love to hear Jia Ying's perspective on this one. 2 points I want to highlight. Suffering. What exactly is suffering?
So we are going very philosophical now.
Exactly. So to me, pain and some of the distressing symptoms associated with, dying, they are very easy to manage. We have the knowledge and skills and the experience to ensure that anybody under my care, for example, or for that matter, my colleagues' care, because we work in teams, it's not just one doctor's job in palliative medicine. It is about a team-based sort of intervention, leveraging on the expertise of the doctors, the nurse, the social workers, the counselors, the art therapists, the physios, to actually do a grand piece of job. So that part I'm quite sure we will be able to sort of manage. But the suffering that is associated with end-of-life care is around acceptance of a reality and letting go. I suppose these are some of my reflections that I have accumulated in my last 2 decades of work in this area, and also including some of the work I did as part of my PhD, studying what a good death means to a dying child. Letting go is something that is easier said than done. And when one doesn't let go, that's where suffering happens. Because there is this tussle or tension between holding on to something which is fast slipping away, and how good can that feeling be? So if you ask me, I think a lot of those very anxious, moments when you press 995, it's around difficulty letting go. And I think that's the part that we, professionals like ourselves in hospice and palliative care are still trying very hard to manage using different, approaches. But I like to think that if we're given enough time, unfortunately, most of the time the patients are referred to us quite late. We are not able to look back, with a caregiver, for example, about guilt, regrets, things that haven't quite been said and all that actually sometimes when it comes to a rush or when you have so little time left, it really ups the tension, and that's when this press 995 thing happens.
Okay.
Ying, what do you think?
Pressing 995 is just one of the things that you may be, you may really want to do at the end of at someone's suffering, when you witness someone suffering. So I was just thinking also, just now, Dr. Chong, you mentioned guilt. I think guilt is a very powerful emotion that is probably what is driving these actions as well. So if I don't call 995, will I be guilty? Have I made the wrong choice? Right? So I think I was thinking about another example actually. So I think coming back to the calling 995 example first, assuming that my family member is already in hospice care and we already know that he or she is dying, then my understanding is that in the hospice systems, there are nurses, there are doctors that are already attached to the patient, and instructions would have been conveyed. What do I do when this happens, right? So hopefully the education is complete, right? That I don't panic when I have this information. Of course, if let's say suddenly my mom falls and passes and goes unconscious, obviously I'll call 995 because she is not dying, right? So I think these are correct responses. I think in my volunteering experience, I think one of the things that actually people can't really let go is to actually be feeding their family member. So at the end of someone's life, given that you're dying already, that your body is shutting down, you no longer need any nutrition, right? You are just fading away. But as the family member, you would feel like, should I be feeding this person, my mom or my dad? If I don't feed, then will he die? I mean, yes, he will die, right? Right? I think there is that fear. If I don't feed, then I would have caused the death. But no, actually, the process is already happening. Actually, the person doesn't want to drink or eat anymore, have no desire to eat or drink anymore, no need to eat or drink anymore, but we would still want to feed because that is our response to life. And when we're facing a dying person, we need to remember that this person is no longer going to have more life. This person is going away. So I think guilt, if I don't feed the person died, then it's my fault. Yeah.
It's so true. I think I resonate with that. And I see that a lot of time. So I suppose there is so much meaning to feeding, particularly in the Asian society, where when you prepare food, whether it's a mom prepares food, milk for a baby, or a mother preparing food for a child, and then now a daughter like yourself preparing food for your mom or dad who is unwell, that speaks a lot, and it is really in our culture, in our psyche, as the right thing to do. And when the situation happens such that you're not able to, or you're prevented to do that, then we are kind of stuck. And that's how I think that meaning making needs to happen. You might understand it cognitively in the head, but at the heart level, it is something you're struggling to grapple with, and that's where I suppose hospice and palliative care comes in. So the science in hospice and palliative care is not really about the biomedical aspects only. That's something we do very well, but we also very well support our caregivers as well as our patients sometimes if they still are mentally sound, thinking about like why me? Why did God punish me this way? It's, some of those existential questions we help the patients to manage. But the caregivers in particular, like in this example, when you cannot feed anymore, then what do? I must send my mom to the hospital because then they can put on drips. They can put on tubes. And I get asked questions all the time. Can we put in a tube because my mom cannot swallow now? I will just have to say, this is a natural anticipated process of dying. And like Jia Ying so beautifully, said it, when someone is in this state, actually they don't need that nutrition anymore. Sometimes we throw in, I won't call them scare tactics, but rather when you feed at this time when somebody doesn't need it, you can do more harm than good. Right. So hopefully some of these explanations would be able to assuage whether it's the guilt, misgivings that some of our caregivers have, and hopefully hold them back from just doing the very sort of panic sort of button response thing. And I think every little thing helps. The only thing is, of course, it is unique to each and every family, and that's the reason why in the work that we do, we need to go really in depth to understand what a family is like on a good day and what a family is struggling with at the moment, and more importantly, what the family is hoping, to work towards in the future. So this might be about how do you want to remember your mom's dying or death? How do you want to sort of recall this experience of serving as a caregiver to your loved one? How would you like your children, for example, to remember how their grandmother, Kong Kong or Nanai, had sort of lived with them so well, so warmly cared for until, they just died naturally. Without all the tubes, whether it's for feeding, for fluids, without all the, paraphernalia of modern medicine, for that matter. So I think to reduce this medicalization of dying, we should bring death and dying back home if it is appropriate, if it is the wish of, the dying. But we should not be too dogmatic about, numbers. It is really understanding what works for each person, each family, and of course, each community.
About dying at home, because I have a friend whose father was in advanced stage of dementia. So he was like really going in and out of hospitals. And then like when he's at home, my friend had to engage a helper, a domestic helper to take care of him. But as caregivers, she was under a lot of stress and all that. And I feel that in Singapore, if I'm not wrong, a lot of all these like elderly they are taken care of by domestic helpers actually. So in order to die at home also, you do need some nursing professionals, or is there anything else, is there anything more can be done to help all these caregivers?
Every year, 20,000 Singaporeans die on the average. So how do you hire so many domestic helpers? We are even short of nurses looking after, patients in the hospital or different healthcare settings. So again, that's not quite the best solution for a major problem of this size. So again, I like to promote the need to then go back to the past to see how dying was like before. How do we manage when dying happens? Are we setting ourselves too high in expectations? Or are we actually mollycoddled into thinking like, I'll just pay this money and outsource this to somebody? But seriously ask yourself, if you are the one dying, actually what do you need the most?
Ying?
I think caregiving is a very, very tough thing to do. I mean, caregiving is a 24/7 job. I have not been a caregiver to someone who is dying or seriously ill, but I mean, I take care of my kids and my nieces and my nephews. I mean, it's a different spectrum of caregiving, but it's the same amount of work. And actually, in terms of attention. And I think in Singapore, or maybe any other developed city, the stress of living is also very high. So if I need to caregive, I have to give up working, right? So what we typically see is that, we will work and we'll hire a domestic worker because financially that makes more sense, right? I will still have some income to support other living items, and I can have a domestic worker care for somebody that I love. So I think I don't really have a solution to this. It's a much wider systemic or cultural or countrywide issue than just something that we can apply one single solution. I have read about facilities overseas. I don't know how good they are, where in a sense, I think it's assisted living, if I'm not wrong. Yeah, where people continue to live at home, but there are professionals who are around to help, I guess, manage the community, and the community then looks out for each other. So I wonder, actually, I'm also thinking for myself when I die or when I am dying, what would I want? And I think one of the things, I don't really want to burden my daughter. And if she needs to go and live, then she should go and live her life. And I wouldn't mind hanging out with other old people or other people who are like me, in a community and living, right? Still living instead of going to a nursing home, or as in what I imagine to be a stereotypical nursing home where there are very regimented schedules and, things like that. Hopefully I'm still able to walk around and be pretty independent, but I do need some assistance, So maybe we can offer different facilities, so-called, right, at different levels, so that there are more options for Singaporeans to go to at this time.
Exactly. Yeah. I suppose what you have described is a kind of model where if the patient is not as ill, yes, certainly has a life-limiting illness, whether it's dementia or some other sort of advanced cancer, and is still semi-independent, and what they need is some assurance that I can get help when I need, or when there's a little accident, I can just press a button and get someone to come to my attention. So I do have a wish myself, when the time comes, I don't know, I hope, in the not too distant future, anybody who is dying and has a family, it just brings us back to, how our ladies get maternity leave. when they give birth to a new baby, I wonder whether caregivers can get paid leave when a loved one, you could define, this loved one could be a parent or even a child who is dying. As I've said, right, a dying person can be a young person or an old person. So if I have a loved one who is dying, can I get paid compassionate leave? Not after the person has died, because that, I suppose, although is important, I subscribe to the idea that it is more meaningful to spend more time with the dying, if we respect that is a priority. To have the person, not be sort of tied down to whether it's work or explaining to their RO or supervisor how they need to take leave. I have got many sort of experiences working with some family caregivers. They tell me that they have exhausted their annual leave and their bosses are not terribly friendly. And here I'm watching somebody dying, either at home, on a hospital bed in the hospital without any visitors. And when I ask, I heard that, the caregiver was called back to the office. Or when I visit them at home, the care is actually outsourced to either a domestic helper or a professional nurse that they use money to buy. So going back to that question about, actually, if you're the one lying on the bed, what exactly do you need? Does it matter whether it is in the home or in the hospital? I think when somebody, and I'm getting quite philosophical here, when one is closing the last chapter in your life, actually, what do you treasure the most in those moments? Is it your car, your mobile phone, or the people that you've lived with, all of your life? Do you want to be surrounded by them? Not necessarily cared for by them, but to have them close to you. And it might even be a dog for all you want, and that's the reason why sometimes we bring dogs into hospital, into our inpatient hospices, because those things mean so much to somebody who is saying their last goodbye and not coming back. That's how significant it is, and that's why very drastic measures need to be taken, because this is only one chance that you're given to, close this last chapter of your life before you turn the book round. So I suppose this is a call to the policymakers out there who are listening to this podcast, anybody who is an advocate or champion in the right places, to think about incentivizing some of these sort of policy making to allow this to happen. Because I think, as I've said, the numbers who are dying, is so many and so high that outsourcing it to whether it's healthcare providers or lay workers like domestic helpers and all that is not the solution. But more importantly, what is so important to anybody, young or old, who is dying? Do we give them that respect or priority that we give to a newborn baby? So you see the Straits Times highlights, any new baby born on the cusp of the brand new year. Nobody celebrates somebody who has died in a warm surrounds of family in the home as the year turns from 2022 to 2023. So I suppose I'm just being very lyrical here, but again, people like myself who've seen so many people come and go, live and die, sometimes just dream of some of these possibilities.
But is it a taboo right now? Do we talk about death too late in their life stages? Do you see younger people coming in to talk about how they want to die?
I started running this thing called a death cafe starting this year in January. So I have actually conducted 7 sessions and we've reached out to about around 50 people. Around 7 to 10 people show up every month. And I don't know whether it's because of my publicity channels, who I reach out to in the first place, or is it really that, this is the demographic who wants to talk about end of life. But I do have a good number. In fact, I would say majority are young people, and young people who are questioning life in the very existential way as well. Some of them have caregiving experiences. Some people have everyday living type of life limiting, certain illnesses. Disabilities, yes, which then limit their potential for life, who are also then thinking about death. So I think in the mainstream media or in our education system, we don't talk about dying enough. And I think it should start earlier. In fact, I was joking, I can't remember, with somebody. So at 40, which I'm hitting close soon, we'll get our Elder Shield
invitation.
Yeah, invitation, right?
Catch you actually.
Right?
Yeah. Even earlier, 35 or 30.
Oh, really?
Yes.
Then I missed my invitation. I thought it's 40. Okay, but anyway, which is okay. So I remember my cousins getting their Elder Shield letters, and then they'll be like, "Oh my gosh, I'm an elder already." So then I'm like, "Hey, why can't we kick in this conversation about end of life as well, right?" I mean, since we're already talking about people being old at 40, then people will die too, right? Yeah. So I think. Coming back to your question, it is still a very taboo topic. I have been very lucky, I think, that people who I meet in the space that I hold are all very open to talking about end of life. I know that in hospice settings, based on accounts from my social workers, there are a lot of people who are very death denying. There will be family members who don't even want to tell their dying family member that they are dying. They want to withhold this information. Some people would not even want to talk about cancer, for example. Don't mention this word. Don't, pretend you're not from the hospice. It's that kind of death denial. So, and even I think I'm also thinking about my own. I guess what I have grown up with as well, that when I tell people that I am trying to be, I am an end of life doula, I can't even talk about it directly, right? Because there is this subconscious part of me that is like, don't talk about death because people may not like it, or it's not auspicious, it's a conversation killer, right? So I think it is very ingrained in all of us. And actually, we have explored this multiple times through the different death cafe sessions that I have organized. And one reason, or at least that I have settled for now, is that as human beings or as living beings, we are programmed to live. So our body will shut down anything that prevents us from doing that. And maybe that is just an automatic mechanism on top of the cultural and how we are being brought up. Yeah, so I think that's that. Yeah.
Dr. Chong, what about you? I mean, we were just discussing that there are some people around the 50s and 60s who are very resistant to talking about death.
I suppose these groups of people, and I mean myself too, until I went to the dark side, are like, they have come out from their youthhood, and they are getting or feeling closer to a different stage of their life. This is the time when their knees started giving way, and they get stomach problems, or some of their friends actually died of heart attacks or whatnot. And it slowly dawns on them that, your clock continues to tick, and your expiry date is coming closer. So as a result, sometimes, like Jia Ying mentioned, people, the knee-jerk response is to move away, to deny that it's happening. Either that, or they go and do a new hairstyle, or go to the gym, to kind of like do a death-defying act almost. Yeah, I have gone through those. And then what I've observed in my experience, especially in the last 10 years, the younger people, those that Jia Ying engaged in her death cafe sessions, and the much older ones, these are the ones who are more open. The younger ones may be thinking that, it will not happen until like decades later, so don't worry about them until then. The very old ones, they are kind of prepared to either meet their maker, or they kind of have resigned themselves to closing their life. And my father, for instance, is a little bit fearful of what's going to happen, what's going to come, where it's going to go. My mom, on the other hand, is like happily making all her funeral plans. Yeah, so it's a bit heterogeneous, but generally they're more prepared. Yep. So therefore, I think we have work to do in the middle age groups and in the younger age groups for them, because these are the ones who are going to become middle-aged, to continue to inculcate in them this fervor for life and this perhaps ability to embrace death if it does come. Because if I really believe that if you live your life very, very well, actually there is nothing left to do, you might really want to go on to, discover what comes after death. Because you're so bored of whatever you're doing right now, you just want to move on. Perhaps maybe that's the way to go. And for the ones who are already, knocking on the door, is to ensure them that, and this is something I hear all the time, I'm not afraid of dying, but I'm afraid of the pain that comes with the dying process. So that's the part where I think hospital palliative care can come into that space to ensure that, look, you don't have to suffer physically in pain or any other forms of distress because you have allowed us to come in to do what we can. And I am fairly confident majority of the cases we would be able to get those under control. As I've said earlier in this discussion, what is hard is accepting the fate and then letting go. And that's that suffering that I think they have to do their own homework. Either within themselves or with individuals in the family, because again, this thing I say all the time to the people I minister to or support. When there is no love, there will be no pain. So it's so easy for somebody who is, loner all this life, has been, not loved by anybody. It's just merely taking one step across the bridge. But for people who have so much encumbrance, connections, bonds, these are the ones who find it so hard to let go. And I think there is lots, that we can do in this space, using different sort of approaches, whether social media or discussions like these, and of course knowledge like science and evidence.
Dr. Chong, you're also the founder of Star Pulse, is to take care of young terminally ill patients, in contrast to elderly patients who may be more prepared for death, as you said just now. How do you take care of these younger patients and also their parents and loved ones?
Thanks for asking this question. I can't wait to tell you all about the work that I do with children who unfortunately get diagnosed with devastating, diagnoses and have their life, which is normally expected to be long and at least, beyond adulthood, to be cut short. Some of our babies die even before they're born, acknowledging that there are some of these losses. Whether it is miscarriages or stillborns. Some of our babies come out and die within the first week or first month or first year of life. And so these are our neonatal losses, another population of children that I look after. And some of our children come out normal and then develop different conditions, whether cancer or other conditions, non-cancerous, and they needed to close their life prematurely. So if you imagine that this wonderful being that is born to a beautiful family of parents or maybe even siblings and grandparents, what kind of effects it would have or impact it creates in this family unit. And that's the work we do in pediatric palliative care, offering all of the above that we discuss in this program and more to help the child as well as his or her significant others to come to terms with the reality and to, prepare to let go. But the same sort of principles or concepts apply, except that I suppose the emotional or psychological burden is, multiplied a few more times, given that this is counter to nature. At the same time, I like to think that doing this work, although emotionally very difficult, I actually learned so much from these children. And I have really sort of transferred some of these lessons that I learned from kids to the care I do with the older adults or even the elderlies that I care for in this big sort of program that I run called HCA Hospice. And I think it has taught me many lessons about living and life itself. And many of these parents, so courageous and so, wonderful, have also helped me to disseminate the message, which is really about life is precious. Treasure every moment. You never know when you will lose it. Yeah.
Okay. So how different are they when it comes to managing their end of life?
I will say that it is almost similar in terms of the technicality. So we still, dish out morphine and whatnot that I'm very famous for. And we do a lot more of the support in terms of the psychosocial, emotional, and sometimes spiritual dimensions. Because again, some of us may be aligned to some religious sort of denominations and have got our own beliefs and values. And when we are challenged like this, in a crisis of this proportion, we start to question, whether there is a God, if at all. Some of these are very hard for these parents to sort of contemplate. So that part of work is very important. The other bit is also about acknowledging that it has an impact on everybody else that surrounds this one family. So I'm talking about, for example, the teenagers that I look after, the friends on Instagram, or other social media, the classmates in school, the teachers and everybody else, and the grandparents. Not forgetting the siblings of these kids, right? They will be all my, beneficiaries that I will need to look after. So I have often gone to schools to meet classes to kind of explain to them why somebody's not coming back to school anymore, or why somebody's coming back but he's attending probably like a fraction of the classes because he really wants to feel like he's back in school again despite the advanced illness, and how perhaps one day they might be attending his funeral. Yeah, things like that. So it's all in a day's work, really challenging, but so rewarding, as I've said, teaching me all about life and living.
Okay. Thanks, Dr. Chong, for sharing, and thanks, Liang, for sharing. Is there any wish that you want to say? How do we improve on palliative care in Singapore? I think we go to Ying first.
Okay, I think I'll start in maybe to make it a very important point. I would like to second Dr. Chong's suggestion of caregivers' leave, in a sense, for end-of-life patients and their family members. Because caregiver stress is really not something to joke about. And the capacity that is needed for caregiving is really a lot of times underestimated. And it would really be very nice. I really think it would be a very good idea to have this caregiving leave that is offered to family members to take care of other family members. Yeah. So I'll just end with that so that it can become a very punctuated point.
So it's not all just whimsical, right? So thank you for seconding that. For me, I suppose I am probably going to contribute at most 10 more years in my professional life, to this cause. This is my second career, having worked as a family physician in the first half of my professional life. And then I joined this charity and have done this work for more than 2 decades. So what I'm hoping to see in the next 10 years is the minister's vision come true. Although it's a lot of work, but we will chip at it. And more importantly, as we've discussed a lot on this program, it's about, everybody being very honest with themselves, to have those conversations that are so important, to confront some of the realities in life, and to then make some of those decisions that they need to make. whether it's in regards to how they spend their life now, what are some of the priorities, what are some of the relationships that are important to them, treasure them, nurture or develop them if they haven't been. And at the right time, when it does happen, to just take that step and cross over without too much, tension, anxiety, or stress, because this is just the way nature, or life flows. I think if everybody can get that equanimity, there will be lots of peace, dignity, and happiness when life closes. Thank you.
Thanks. Once again, I'd like to thank my guests, Dr. Chong and Ying, for your time today. Thank you all for listening in. See you on the next episode on Diversity. On Diversity is a podcast inspired by the Institute of Policy Studies Managing Diversity's research program. We are available on Omni.fm, Apple Podcasts, Google Podcasts, and Spotify. Please follow or subscribe to get notified when we have a new episode. You can visit our website, ipscommons.sg, for more info.